Welcome everybody. Today we are talking about a very broad subject in emergency department, which is toxicology. General principles of poisoned patient. Generally, there are something that you have to do for all poisoned patient. When a student is asked about a poisoned patient or an overdose, they usually directly jump to the antidote that's used. But actually, they forget that the vast majority of poison management is good supportive care. So what are the general principles? You can break down to 5 elements. The first one is ABCD assessment. Whenever a patient comes to you with any type of poisoning, you have to do airway, breathing, circulation, and then supportive management. Decontamination. So you decontaminate the poisoning either by dry decontamination, by wet decontamination, by activated charcoal or gastric lavage, whole bowel irrigation, then elimination. So then the third thing is you have to eliminate if you can. Usually decontamination done in the first hour. Then in the fourth step you have to give antidote. Sometimes antidotes are not available for many drugs and for many poisons. And if available, it has specific indications to give. Then finally, before discharge of the patient, you have to do psychiatric assessment because some of them, they have some sort of suicidal ideations. Coming to ABCDE, so about the ABCDE, airway, all patients presenting with poisoning patient, you have to do a thorough ABCD and do a good supportive management. In the airway, if the patient's airway is inadequate, you have to provide endotracheal intubation if necessary, especially if the patient is unconscious and there is no reversible drug to do it. So if the patient is not intubated, if the loss of consciousness, for example, is temporary, you have to put the patient in recovery position, left lateral, in order to minimize the risk of aspiration if vomiting happens. Coming to breathing, monitor the breathing. If the ventilation, if the respiratory rate is inadequate, you may use bag valve mask, I mean ambobac. If the patient having respiratory failure leading to hypoxia and hypercarbia, you have to call the RCU and they may intubate the patient. Coming to circulation, if the patient is hypotensive, you have to start with giving fluid to revert back hypovolemia. If arrhythmia, anti-arrhythmic drug is sometimes being given. If there is cardiac suppression, you may give inotropic vasopressors. So you may give 500 ml boluses or 250 ml boluses of crystalloid, normal saline or ringer lactate to the patient. Then some patients may need inotropic support, noradrenaline or dopamine. Arrhythmias are uncommon in poisoning patients, but if happen, usually they are due to hypoxia, hypercarbia, acidosis, electrolyte abnormality. So if you correct these anti-arrhythmic drugs are rarely needed. Coming to disability. So for disability, you have to check the conscious level of the patient, random blood sugar, look at the pupil, and also do the lateralizing sign. This lateralizing sign. So if the patient is in convulsion, you have to give benzodiazepine. If the patient is hypoglycemic, you have to give hypertonic glucose. And coming to the E, exposure, you have to check the temperature of the patient. Of course, you have to check also for the glucose. So normothermia should be applied for most of these patients. And also look for any evidence of injuries or rashes or lacerations, particularly to the head. So this was the ABCD. Second step is decontamination. In the decontamination, the aim of the decontamination is to stop the substance being absorbed. There are various forms of decontamination, including skin decontamination. For example, if a patient exposed to organophosphorus poisoning or any acid or alkaline, you may have dry decontamination or wet decontamination. Dry decontamination usually used for patients who have some sort of powders on their body. So in this type of decontamination, what you do is that you may use a towel or something like a tissue paper, and then you clean it. In the wet decontamination, you may use water in order to wash it. Activated charcoal. The activated charcoal is used in 50-gram doses if in the first hour of the poisoning. The patient should be conscious and not coma state, because if coma, it may lead to aspiration pneumonia. So for gastric lavage, it is rarely indicated, but usually you have to consider it in the first hour of the severe poisoning, life-threatening poisoning, not all the poisoning. Of course, the airway should be protected if the patient is unconscious, because to prevent aspiration pneumonia. We have whole bowel irrigation by some drugs like clean prep, which causes strong diarrhea and clean diarrhea. This is usually used for drugs which has long action, or they are come in slow release preparations. Induced emesis, previously they were giving some drugs like ipecacuanha, but nowadays it is not recommended, no longer recommended to do the vomiting of the patient. Activated charcoal, it absorbs substances onto its surface by weak electrostatic forces, thereby preventing absorption of the ingested drug. This is called gut decontamination. The dose is 50 gram orally, and for children it is usually 1 gram per kg. It should be given, as we said, within the first hour of the substances that do not bind to activated charcoal are iron and ethanol, stroke acids and alkaline, also petroleum, ethyl glycol. So there are some drugs that cannot be bound, and organophosphate cannot bind to activated charcoal. And there are some drugs which are slow release, example carbamazepine, digoxin, theophylline. These drugs usually have narrow index, therapeutic index, so can be repeated 4 times for every 4 hours. In elimination, active elimination is rarely required in poisoning. It can be achieved by several techniques depending upon the poisoning. For example, some weak acids, example salicylate poisoning like aspirin, you need urinary alkalization by giving sodium bicarbonate. In severe salicylate poisoning, especially if taken more than 900 milligram per kilogram, you may need hemodialysis. Also in ethyl glycol, which is antifreeze, methanol, lithium, phenobarbital, you may need hemodialysis. Hemoperfusion for barbiturates, theophylline, choral hydrate. So usually you have to know that for salicylate you may use urinary alkalization. Others you have to consult the nephrologist in order to ask them about the possibility of the hemodialysis. Coming to antidote, for every drug of this you may have some antidotes, but other drugs don't have antidote. For example, in paracetamol you may give N-acetylcysteine. Now the methionine is no more indicated. Acetylcysteine is indicated if more than 150 milligram per kg been taken. It should be given started within the first 8 hours. Better to check the paracetamol level before giving this drug. We will have a special lecture about paracetamol and how you give this antidote. Coming to opiates. In opiate poisoning, you may give naloxone, but naloxone only given if the patient have decreased respiratory rate, respiratory depression, if the patient is unconscious, decreased level of consciousness, or sometimes airway obstruction. So in these cases, you give opiates. Benzodiazepine. Benzodiazepine, if the patient is becoming respiratory depression or even in cardiac arrest, you may give flumazenil, but be careful. It should not be given in mixed overdose, especially if taken with tricyclic antidepressant, because it may lead to convulsions if you give flumazenil. Beta blocker. In beta blocker poisoning, usually if the patient have bradycardia, hypotension, I mean if there is cardiovascular effect is being started, you give glucagon. Glucagon is the antidote. If the patient is having bradycardia, you give atropine. If the patient is having bronchospasm, you give salbutamol. If the patient have hypotension, which is resistant to glucagon, you start giving glucose and insulin together. You give 1 unit per kg of insulin, and also give glucose accordingly to prevent hypoglycemia. If the patient in cardiac arrest, you may give also lipid emulsion, which is most of the time not available in most emergency departments. You also give inotropes to support the heart. Coming to tricyclic antidepressant. I will talk in more detail about tricyclic antidepressant later, but the antidote is sodium bicarbonate. Iron. In iron overdose, you give desferoxamine. When the patient is having iron overdose, just be careful that in the first few hours, usually the patient is in the first 6 hours, the patient have gastrointestinal symptoms like nausea, vomiting, diarrhea, GI bleeding. Then if the patient have severe poisoning after 6 to 12 hours, they are asymptomatic. So until 0 to 6 hours, they have GI symptoms. Then between 6 to 12 hours, usually they are asymptomatic, and many patients, they say we are improved and we go home. But later, after 12 hours, the patient will get into shock, into respiratory failure, and the patient will get coma. So in iron overdose, after few days, the patient may get gastric scarring, also some strictures in the pylorus. So this is usually if the patient is survived. So any patient who is symptomatic and taken a high dose of iron, they should take desferoxamine. Or even if the patient is asymptomatic, but the serum iron level is constantly elevating, then you have to also give desferoxamine. Calcium channel blocker. If the patient is taking calcium channel blocker, it's very toxic, especially in children. You give calcium gluconate or calcium chloride. Patients who are resistant to this, you have to start with insulin glucose, like that one in the beta blocker. You may also need lipid emulsion, inotrope, and even glucagon can be given. For bradycardic patient, you give atropine. Coming to carbon monoxide poisoning, CO poisoning. In CO poisoning, what you do is that if the patient is coming to emergency department, directly you start oxygen. Hyperbaric oxygen nowadays not indicated and not available in most centers. You have to do carboxyhemoglobin level, because oxygen level or SpO2 is usually first reading normal. But if you do IBG and in the IBG it contains carboxyhemoglobin, it is usually more than 10. Coming to digoxin, if there is digoxin toxicity, you have to start digoxin specific antibodies. Ethinyl glycol, which is antifreeze. If the patient is taking antifreeze, they start with visual disturbances, then they will get, the patient will be blind if not treated. Then they will get acidosis and renal failure and heart failure. And then they will die with multi-organ failure. What is the antidote for ethinyl glycol, for antifreeze? By the way, if you take more than 100 ml, you will absolutely, it is toxic. You give alcohol. Different types of alcohol can be given. So you give ethanol for the patient. Fomepizole is also a good antidote if available, but it is very costly and usually not available. Organophosphate poisoning. We will talk about organophosphate poisoning and how we give atropine, and sometimes also we give pralidoxim. Cyanide poisoning. Cyanide poisoning is happening when the patient is exposed to plastic fumes. So usually the patient will be having loss of consciousness within 30 seconds of exposure to cyanide. Cyanide poisoning happens in, as we said, if there is a closed home, a closed room, and there is plastic fumes. So there will be anaerobic metabolism. You have to use hydroxycobalamin, sodium nitrate, or thiosulfate. Now they editate decolbide editate is not available and not indicated. Sulfonylurea. Sulfonylurea is the drug that is used for patients with diabetes. For example, glimepiride, glibenclamide, gliburide. So if the patient coming with sulfonylurea poisoning, the first thing they will get hypoglycemia. So you have to give glucose. It is better to transfuse 100 ml per hour constantly glucose water. If the patient has severe hypoglycemia, give hypertonic glucose. The antidote for sulfonylurea is octreotide, which counteracts the effect of beta cells of pancreas. Warfarin. If a patient have warfarin and the INR is high, you have to give vitamin K. But usually vitamin K needs about 6 hours to revert back the effects of warfarin. So if the patient is actively bleeding, it is better to give prothrombin complex concentrate, PCC. If not available, give fresh frozen plasma. Fresh frozen plasma contains every anticoagulant that you need to stop the bleeding of warfarin effect. Then after you have given antidote, a more focused history should be taken from the patient to identify the likely type of toxin, plus the amount that been taken, the time of the ingestion, and also the medications that the patient is concurrently taking, because there are some drugs have side effects and also interactions with each other. Then the physical examination should look for signs providing clues to the cause of the poisoning and further particular features of supportive for a toxicodrome. Once the patient has been assessed for the medical consequence of poisoning and treatment being initiated, psychiatric assessment can be started to know whether the patient is having any suicidal idea and also to prevent further episodes of this what happened. Toxidrome. What is toxidrome? Toxidrome is constellation or collection of some symptoms that show the specific class of poisoning. The most common clinical toxidromes are sympathomimetic, anticholinergic, cholinergic, and opioid. So this, coming to sympathomimetic toxidrome, it is caused by drugs such as cocaine. amphetamine. Also, sometimes even theophylline can cause sympathomimetic effect. It leads to the patient usually having sweating, hyperthermia, and also hypertension, chest pain, agitation. So the patient will be excited. If the patient is not treated, it might lead to intracranial bleeding, agitation, delirium, hallucination, and also leading to seizures and multi-organ failure. Usually the treatment is supportive. And the treatment is supportive. What we mean by supportive treatment? For example, if the patient is agitated, you have to put them in a quiet room. If there is psychosis and irritability, you give them oral, or if not tolerating, you give them IV diazepam. Give them 10 to 20 milligrams of diazepam. If the patient is having increasing temperature, you may do some spraying of water and fanning in order to decrease their temperature. You do ice packs to groin and axilla if the patient have increased temperature. And sometimes even you may need lavages, example, gastric lavage, bladder lavage with cold fluid. If there is ECG changes due to sympathomimetic drug, you may give sodium bicarbonate. So if there is ECG changes, you give NaHCO3, sodium bicarbonate, in the dose of 50 to 100 ml of 8.4% of sodium bicarbonate. If there is sinus tachycardia, you may give them benzodiazepine. If the patient have elevated blood pressure, if the patient having elevated blood pressure, you give them benzodiazepine. If not treated, then you have to give IV GTN, or even first you can start with sublingual. If still not improved, you have to give them labetalol. For the chest pain, think about giving diazepam, then think about acute coronary syndrome and activate catheter lab. So you may need primary PCI or even thrombolysis if PCI not available. If the patient is asymptomatic, if the patient of sympathomimetic toxidrome asymptomatic, for 4 hours, then you can discharge him. One of the drugs that causing this toxidrome is called ecstasy and NMDA. So one of them is NMDA. NMDA was commonly used as have a street names like ecstasy, or some of them calling it M&M drug or XTC. So these drugs were commonly using, also causing hyponatremia. Same treatment line is used for sympathomimetic toxidrome for this one. Coming to anticholinergic toxidrome. Anticholinergic toxidrome caused by drugs such as tricyclic antidepressants, also antipsychotics. There will be the clinical features remembered by mad as hatter, hot as hair, blind as bat, red as beet, and dry as a bone. What do we mean by that? We mean by that, mad, the patient will get psychosis. Hot, there will be flushed skin. Blind, because there is mydriasis, there will be dilated pupil, so the patient have blurred vision. Red as a beet, there is also flushed skin. And dry, there will be dry skin. So the treatment is supportive. We give benzodiazepine if the patient is having agitation or seizure. Cooling may be required if the patient having high temperature. Treatment is usually supportive. Another toxidrome is cholinergic toxidrome. The cholinergic toxidrome is caused by organophosphates and carbamidase. So many insecticides and plant fertilizers contain organophosphate, so they will get some symptoms. The symptoms can be remembered by a mnemonic which is called dumbbells. D for diarrhea, U for excessive urination, M for muscle fasciculation and paralysis, B for bronchoria or bronchoconstriction, so there will be excessive secretion from the respiratory tract, and there will be also bronchoconstriction. Another B is for bradycardia, E emesis, repeated vomiting, L lacrimation, also the patient is lethargic, S stands for excessive salivation from the patient. The treatment is atropine. High doses of atropine might be needed. Before that, you may decontaminate the patient in order to prevent further absorption of the material. Wet decontamination is usually indicated in these cases. Coming to the atropine, how we give atropine? Usually we give 0.5 to 1 milligram of atropine. If the patient not improve it, you give 2, you give double dose, then you give 4 milligram, then you give 8 milligram. Sometimes large doses may be needed until the patient is atropinized. So what is your goal? Your goal is a mean arterial pressure that is more than 80 millimeter mercury. Your heart rate, the heart rate of the patient should reach more than 80, and also the lungs should be clean. So clear lungs, there is no further secretions. In this situation, then you say that I atropinized the patient and I made the patient away from the risk of cholinergic toxidrome. Then after that, you give 20% of the dose that's required for the patient. For example, if the patient has taken 10 milligram in order to get this result, then you give 2 milligram per hour as a maintenance. Sometimes, if available, pralidoxim is given for moderate to severe poisoning, and most of the time in our emergency departments, not available. So there will be fluid everywhere in patients with a cholinergic toxidrome. Opiate toxidrome. It results in opiate. What we mean by opiate? The drug is like morphine, pethidine, heroin, fentanyl, even loperamide. Loperamide, which is used as a stopping antidiarrheal agent. So these patients, it results in respiratory depression. It results in decreased respiratory rate, decreased conscious level. It leads to constriction of the pupil, meiosis, and hypotension. So everything will be reduced. If the patient get these symptoms, you have to treat them with naloxone and also do supportive therapy. The naloxone dose is 0.4 milligram. If the patient not improve after 1 minute, you use 0.8 milligram. If not improve after 1 minute, another 0.8 milligram. The dose up to 2 milligram can be used. If the patient, what is your goal? Your goal is to increase the conscious level to about 12 or 13. And also try to follow up the patient for few hours and give them naloxone, because the effect of naloxone is shorter than the opioid itself. So many times you give antidote, the patient improves, then later or after few minutes the patient will get unconsciousness again. So this is the opioid toxidrome, oxycodone, hydroxycodone, or the patient having narcotic drugs, they will get somnolence, meiosis, decreased respiratory rate, and also there might be possible track markers in the site of the injections. If you check their pocket, you may find some needles and syringes in their pocket. There might be also hypotension and hypothermia. If the patient is chronically remain on a heart surface, they may kill rhabdomyolysis and compartment syndrome if not recognized early. Let's come to some other poisoning and go into more detail. Example, salicylate poisoning, aspirin overdose. Aspirin overdose, usually aspirin is a derivative of salicylic acid. It's metabolized in the liver and excreted in the urine. If taken in high concentration, it usually directly stimulates the respiratory center. It causes a respiratory alkalosis. So the accumulation of metabolites and salicylate derivatives results in metabolic acidosis. So metabolic acidosis usually happens later. Respiratory alkalosis in the first, then there will be mixed respiratory alkalosis and metabolic acidosis. In children, the acidosis can usually predominate. So what is the level? If more than 125 milligram taken, it is mild poisoning. Usually there will be some nausea, vomiting, there will be tinnitus, there will be deafness, lethargy. But if more than 250 milligram per kg been taken, the patient will be restless, and there will be also some bounding pulse. And if more than 500 milligram per kg been taken, there will be CNS depression, there will be cardiovascular depression, there will be respiratory system depression. So the patient will get hypotension, shock. So if the patient is taken a mild dose, you may take more than 125 milligram. You do activated charcoal. You start with activated charcoal. And then if more than 500 milligram been taken life-threatening dose, you also do gastric lavage. What is the antidote? The antidote for this patient is with salicylate poisoning is sodium bicarbonate. Although it's usually used to do a urinary alkalinization. The urinary alkalinization, the aim is for a pH of more than 7.5. So the dose of it is 8.4%. You give 250 ml over 1 hour time. If the patient is asymptomatic for 6 hours and the pH is normal, so you can discharge the patient. But if high dose is taken, then you have to follow up the patient. Tricyclic antidepressant poisoning. So tricyclic antidepressant poisoning is a class of drug that has various effects in the body. If taken more than 50 milligram per deciliter per milligram per kg, usually it is toxic. So what are these various effects? It might lead to CNS depression. The patient becomes in coma or decreased level of consciousness. Anticholinergic effects like urinary retention, dilated pupil, increase in the temperature, confusion. So the anticholinergic tox syndrome that we talked about. Cardiac sodium channel blocker. This may lead to prolongation. Of the PR interval, prolongation of the QRS, prolongation of the QT interval. Alpha adrenergic blocking effect. This may lead to vasodilatation. The vasodilatation. This vasodilatation reflexly will lead to increase in the heart rate and decrease in the blood pressure. So it leads to shock to the patient. The investigations for this patient, most importantly, is ECG to look for these changes. Also, you look for the ABG because many patients will get acidosis. Also, you may do renal function test and maybe creatinine kinase. You do glucose level. So the treatment is usually starting with supportive management with ABCDE. If the patient is having severe hypotension, what you do? First, you have to give fluid. Either you give NaCl like normal saline or Ringer's lactate. Then if the patient not improving, you give NaHCO3, sodium bicarb, which is the antidote. Then if the patient still not improving, you give noradrenaline or vasopressors. Then still if the patient not improving, you can give glucagon. The whole story is that if the patient is having hypotension, start with fluid and then give sodium bicarbonate. If not improve, give inotropic agent. The antidote is indicated if on ECG, if the patient is having QRS more than 120 millisecond. If the patient is having arrhythmia, if you take blood pressure, the patient having shock, or if you do a ABG or VBG, you find acidosis, then you give sodium bicarbonate to the patient. In general, don't forget that most of the poisoned patient or overdose patients, they don't need directly the antidote. Most of them, they need to start with ABCDE, supportive management, then decontamination, then elimination, then antidote, then psychiatric assessment. It is better for every poisoned patient to have a file and a police paper because most of them, they have medical legal issues to deal with. What we left is that paracetamol poisoning, I will have a special recording about paracetamol poisoning and how the antidote and when the antidote is being given. Thank you so much.